Hello and welcome to the ECG interpretation topic in the core clinical skills. We will be learning the basics and concepts of electrocardiography, rhythm rate axis of the heart, and ECG interpretation in terms of segments, complexes, intervals, and waves. Let's get started. William Einthoven was a Dutch doctor and a physiologist. He invented the first practical electrograph in 1895 and received the Nobel Prize in Physiology or Medicine in 1924 for the discovery. This is a photograph of a complete ECG showing the manner in which the electrodes are attached to the patient, in this case the hands and one foot being immersed in jars of salt solution. In 1895, William Einthoven assigned the letters P, Q, R, S, T to the deflections in the theoretical waveform he created using equations which corrected the actual waveform. When a more precise waveform was obtained using the string galvanometer, which matched the corrected capillary electrometer waveform, he then continued using the letters P, Q, R, and S, T, and these letters are still in use up to date. The electrical conduction of the heart is picked up and demonstrated by the 12 leads on a 12-lead ECG. There are 3 bipolar limb leads, 3 unipolar augmented leads, and 6 unipolar chest leads. The electrons move from a negatively charged rods to positively charged rods, and the direction of which they move towards is in the direction of the waveform. So as shown in the figure on the left, lead 1 captures the lateral aspect of the heart, lead 2 and 3 looks at the inferior aspect of the heart. The augmented unipolar leads are at an angle as we are looking at the heart in a 3-dimensional form. AVR reflects the right side, AVL the left side, and AVF the inferior aspect. Now finally, the unipolar chest leads. If the heart is cut mid-section as shown in the image, you will notice the leads that capture the different areas of the heart. V1 and V2 captures the right ventricle, V3 and V4 would be the septum, V5 and V6 would be the left side of the heart. Leads placement are the most crucial step in performing an ECG, and these steps will be further elaborated in the procedure module. As shown in this slide, there are 4 limb electrodes, which will be clipped to the peripheries of each limb. Check the labels before clipping them on, as the colors may differ depending on the manufacturer. The 6 chest electrodes are attached to the chest. V1 at the 4th right intercostal space by the sternal border, V2 at the 4th left intercostal space by the sternal border, V4 at the 5th left intercostal space mid-clavicular line, V3 in between V2 and V4, V5 at the 5th left intercostal space anterior axillary line, and finally V6 at the 5th left intercostal space mid-axillary line. A complete set of right-sided leads is obtained by placing leads V1 to V6 in a mirror image position on the right side of the heart. This is an ECG waveform. Here we would like to introduce you to the different sections of the ECG. First, let's begin with the waves. We have the P wave and the T wave. The P wave represents atrial depolarization or contraction, and the T wave represents ventricular repolarization or relaxation, which is the time in which the ventricles take to relax from end of systole to end of diastole. Next, we will take a look at the QRS complex, which is the ventricular depolarization and which also coincides with atrial repolarization. Moving on to the intervals, PR interval is the point at which atrial depolarization begins and the electrical signal reaches the Purkinje fibers, after which it passes through the bundle of His. Prolonged interval here indicates delay of conduction at the AV node and the bundle of His. QT interval is the point at which ventricular depolarization begins and electrical signal leaves the ventricles, which marks the end of repolarization. A prolonged QT interval indicates that ventricular relaxation is delayed, which may predispose to an arrhythmia as the next signal release is being triggered by other parts of the heart. Lastly, we have the segments. The PR segment is the flat line between the end of P wave and the start of QRS complex. The PR segment reflects the time delay between atrial and ventricular activation. ST segment is the flat isoelectric section of the ECG between the end of S wave, which is the J point, and the beginning of the T wave. The ST segment represents the interval between ventricular depolarization and repolarization. Let's now look at the different areas of the heart which are supplied by different branches of the coronary artery. So the area of the heart which is on the right hand side is supplied by the right coronary artery, and the type of lesions that one would expect to see would include inferior myocardial infarction, inferior plus right ventricular MI, inferolateral MI, and inferoposterior MI. As for an LAD lesion, which is a left anterior descending lesion, you'd expect to see a septal MI, anterior MI, and lateral MI. A left circumflex lesion would bring about posterior MI, posterolateral MI, and inferoposterior MI. Before you begin interpreting an ECG, ensure that you have standardized the ECG parameters. The horizontal axis is time. One large box is equivalent to 5 small boxes of 0.04 seconds, which makes 0.2 seconds. The vertical axis is the voltage, and 2 large boxes of 10 millimeters is equivalent to 1 millivolt. Now, we are moving on to the rhythm check. As you look at the rhythm, locate the QRS segment, which represents the depolarization within the ventricles and 2 lower chambers of the heart that gather and expel the blood towards the body and lungs. Within the QRS, identify the R wave, the positive wave above the isoelectric line or the baseline. Using a 6-second strip, measure the R to R intervals between QRS segments and determine if the rhythm is regular or irregular. Now, let's move on to heart rate calculation. The first and fast method is by using the rule of 300. Count the number of boxes between the RR interval and divide 300 by the number of boxes. Another method is using the 6-second strip of ECG paper and count the number of QRS complexes and multiply by 10 to arrive to a minute heart rate. Now, the axis of the heart. So here mainly we will look at lead 1 and AVF. The term electrical axis of the QRS refers to the mean manifest electrical potential in space responsible for this electrocardiographic complex. This potential has both size and direction, and it may be treated as a vectorial quantity. In particular, there is recent emphasis upon axis deviation as primary information in the diagnosis of those intraventricular conduction defects, now called the fascicular blocks, as well as certain congenital defects, notably endocardial cushion defects and conduction system injuries after cardiac surgery. Since the left ventricle makes up most of the heart muscle under normal circumstances, normal cardiac axis is directed downward and slightly to the left. So you can see here the normal axis is where the QRS is between minus 30 to positive 90 degrees. Abnormal axis deviation indicate underlying pathology, and it's demonstrated by right axis deviation where the QRS axis is greater than 90 degrees, extreme axis deviation where the QRS axis is between minus 90 and 180, also known as the northwest axis, and left axis deviation where the axis is less than minus 30 degrees. Now, let's look at the P wave, which indicates atrial depolarization. There are 2 abnormalities that you need to take note of, which is P pulmonale, a tall P, and P mitrale, which is a broad bifid P. And this slide shows you the abnormal measurements for us to take note of in order to suspect presence of right atrial enlargement, where the P wave's height is more than 2.5 millimeters, and for the P mitrale, the space between the P wave, the width of the P wave is more than 0.12 seconds. So what are the significance of these two abnormalities? P pulmonale is seen in conditions where there is cor pulmonale or evidence of right atrial enlargement, and this can happen in atrial septal defect, in cor pulmonale, pulmonary embolism, tricuspid and pulmonary valve pathologies, or pulmonary hypertension. P mitrale is seen in left atrial abnormalities such as mitral or aortic valve pathologies, especially mitral stenosis. Next, let's look at the PR interval. And here it is the duration. The normal duration would be 0.12 seconds to 0.20 seconds. It's the beginning of the atrial contraction until the end of atrial contraction and beginning of the ventricular depolarization. So there are two abnormalities to take note of, which are the shortened PR interval seen in WPW syndrome and prolonged PR interval, which is seen in first degree and second degree heart blocks. Next would be the QRS complex, and this reflects ventricular depolarization. The normal duration is 0.06 to 0.12 seconds. An easy way to remember would be 2 boxes, not more than 3 boxes. Now, Q wave. Is it always pathological? Well, myocardial ischemia causes XT segment depression with or without T wave inversion as a result of altered repolarization. Myocardial infarction causes deep Q waves as a result of absence of depolarization current from deep dead tissue and receding currents from the opposite side of the heart. So, in order for us to consider Q wave as pathological, the height would be at least a third of the QRS complex, and the width would be at least one small box duration or 0.04 seconds. Next would be R wave progression. So R wave progression is typically seen to reflect the contractility of the heart and whether if there's any presence of ischemia. So this is how a normal R wave progresses throughout the V1 to V6 leads. If there's poor R wave progression, shown by an example of this ECG, the causes could include prior anterior myocardial infarction, left ventricular hypertrophy, LVH or LBBB, wrong lead placement, especially in obese individuals, and a variant of normal. So you might always want to correlate clinical context with the ECG findings, and this will give you a better idea on what does the poor R wave progression mean. Next, let's take a look at right bundle branch block or RBBB. So this is first characterized by a QRS complex or duration of more than 120 milliseconds or 0.12 seconds. You'll be able to see the RSR pattern in V1 to V3, which is M-shaped QRS complex as shown here. And there would be a wide slurred S wave in lateral leads, which is lead V1, AVL, V5 to V6. In other words, you'll be able to see an M pattern in lead V1 and W pattern in lead V6. And that's called the marrow pattern, where you begin with M and you end with W. Causes of right bundle branch block include ischemic heart disease, right ventricular hypertrophy or cor pulmonale, pulmonary embolism, congenital heart diseases like ASD, and a normal variant which is seen in the young individuals. Next would be left bundle branch block. Similarly here, the QRS duration has to be more than 120 milliseconds. There will be a dominant S wave in V1 as shown here, a broad monophasic R wave in lateral leads, absence of Q waves in lateral leads, and prolonged R wave peak time, which is more than 60 milliseconds in leads V5 to V6. Here, typically, you will see the W pattern in lead V1 and M pattern in lead V6, which is known as William, which begins with a W and ends with an M. Causes include anterior myocardial infarction, ischemic heart diseases, hypertension, dilated cardiomyopathy, aortic stenosis, and age degeneration of conductive system. So remember that left bundle branch block is always pathological. Now let's look at left ventricular hypertrophy. Here we will use both the voltage criteria and the non-voltage criteria. So if we are looking at the voltage criteria, we'd want to see both the limb leads as well as the precordial leads. For the limb leads, there would be R wave in lead 1 and S wave in lead 3, which is more than 25 millimeters. The R wave in AVL is more than 11. The R wave in AVF is more than 22 millimeters, and the S wave in AVR is more than 14 millimeters. So these are the numbers that sometimes you might need to consider or remember in order to pick up or suspect left ventricular hypertrophy. However, there are other easier methods that we'll be looking at shortly. And if you're looking at precordial leads, the R wave in V4, V5 or V6 is more than 26 millimeters. The R wave in V5 or V6 plus F wave, S wave in V1 is more than 35. And the largest R wave plus the largest S wave in precordial leads are more than 45. Now, as for the non-voltage criteria, we are looking at ST segment depression and T wave inversion in the left-sided leads, also known as left ventricular strain pattern. So as you can see here, an easy way to remember would be summing up the S wave in V1 or V2 and the R wave in V5 and V6. And if it's more than or equals to 35 millimeters, which is 7 big boxes, this would indicate presence of left ventricular hypertrophy. Also look at ST depression or a strain pattern in the lateral leads, and this will be further confirming the presence of left ventricular hypertrophy on an ECG. Next would be right ventricular hypertrophy. As you can see, the resultant vectors going towards the right hand side. There's right axis deviation quite clearly. The QRS duration here is less than 120 milliseconds, and the changes here is not due to right bundle branch block. Among other supporting criteria you want to look at would be right atrial enlargement or P pulmonale, right ventricular strain pattern, which is ST depression or T wave inversion in the right precordial leads and inferior leads, deep S waves in the lateral leads, and right bundle branch block, which could be complete or incomplete. Now let's take a look at tall R waves. So what are the common causes of tall R waves? These include Wilf-Parkinson-White syndrome, which is shown by the presence of delta waves, right bundle branch block, where you would see an RSR pattern in lead V1, there would be a wide terminal S wave in leads 1 and V6. Right ventricular hypertrophy, where there's right axis deviation and right ventricular strain. Posterior infarction, seen by evidence of inferior infarction. Hypertrophic cardiomyopathy, and also it could be a normal variant. Next is ST segment elevation. So we'll be looking at both elevation and depression. For elevation, so the ST segment represents ventricular repolarization. Repolarization follows upon contraction and depolarization. During the repolarization, the cardiac myocytes elongate and prepare for the next heartbeat. This process takes much more time than the depolarization process. So the elongation that takes place during repolarization is not passive. It is an active process during which energy is consumed. So on the ECG, the repolarization phase starts at the junction or the J point, which is the point after the end of the S wave. And it continues until the T. Now let's take a look at causes of elevation, which can be remembered as its term itself, which is elevation. E for electrolytes, L for left bundle branch block, E for early repolarization, V for ventricular hypertrophy, A for aneurysm, T for treatment such as pericardiocentesis, I for injury such as acute anterior myocardial infarction or contusion, O for Osborne waves in hypothermia, and N for non-occlusive vasospasms. So the image on the right here shows you the various patterns of ST segment elevation, which is present in different conditions or causes as I mentioned earlier. Take note of the location of the J point in each segment and also the shape of ST elevation, whether it's convex or concave. How about ST depression? So there are a few types of ST depression as shown here. We have the upsloping, the horizontal, and the downsloping. Just remember the common causes of ST depression, which include ischemia, and this reflects subendocardial infarction in myocardial infarction, strain, digitalis effect, and electrolyte abnormalities such as hypokalemia or hypomagnesemia. Next is the T wave. So the common abnormality seen would be a tall T wave, and these are the three different presentations of tall T wave. Firstly, hyperkalemia. So take note that it is always symmetrical with a very narrow base and pointed as well as tenting. If you look at hyperacute ischemia, it's symmetrical with a broad base as compared to hyperkalemia, which has a narrow base, and it's not tented or pointed. And finally, you also have it in the form of normal variant, where it's asymmetrical and it's not narrow as well. The last section that we will be looking at in ECG interpretation is the QT interval. So the abnormalities here that I like to highlight would be the prolonged QT interval. Take note of the causes of prolonged QT interval, which can be quickly summarized with the mnemonic DHL, D for drugs, for type 1A and type 3 antiarrhythmics and tricyclic antidepressants, H, which stands for head, so any injuries to the brain such as stroke, seizures, coma or bleeding, and L, which represents electrolytes, lights, such as hypokalemia, hypomagnesemia, and hypocalcemia. So we have come to the end of this session. Thank you for your time.